Hello, everyone. This is Annalyn Schooley of the Florida Family Therapy Alliance. I am so excited to be introducing Darkus Matawi. Dr. Matawi received her PhD from Nova Southeastern, same place I did. In fact, Dorcas and I worked together for a while clinically, and even though this is the Florida group, she is no longer in Florida, but I roped her back in to talk to us anyway. I'm so excited for her tonight to talk about her dissertation topic. And if you saw the announcement for this, you know that Dorcas is a therapist, an MFT. She's a supervisor. She teaches. She's a researcher. She was a minority fellowship doctoral. What do they call them? Candidates? No.
A fellow,
Researchers,
yeah,
fellow. She was a
yeah.
fellow, though she's definitely a lady, but she was a fellow. And part of your dissertation, I believe, came out of some of the stuff you did for the minority fellowship, if I recall. So I'm very excited to have her this evening, and I turn it over to you, Dr. Matawi.
Thank you very much, Dr. Schooley. It's always a pleasure to be around you. I love your energy, and you know that anyway. I miss, collaborating with you, being in your supervision group, and being in private practice. I think that's one of the hardest things. It's very lonely. You are isolated. So I think that is one of the benefits of teaching, where you do get to engage with students, but private practice is a lonely place. But I am trying to change that, and so we'll see how it goes. But I am excited to be here and to share a topic that is very dear to me. I actually developed an interest in racial and ethnic health disparities as a minority fellow. So when I was awarded the fellowship the first time in 2016, I worked with an excellent researcher from Kent State University, Dr. Jared Durchie, and he really helped me narrow down my areas of interest. So it always boiled down to issues that I would see in therapy, clients who couldn't afford to pay or were struggling to get to sessions, or, not being able to afford healthcare, just societal things that I would witness that would trickle into mental health. And so the first study I did focused on, some of the health disparities. When I was awarded the fellowship the second time, I made it very specific to racial and ethnic health disparities. And then when I went into my dissertation, I decided to find out, well, what do MFTs know about racial and ethnic health disparities? And at the time, it was very little. This was before the pandemic. This was before George Floyd. So people were living their lives and not really thinking about, societal issues. So it was an informative research study. And, I've done presentations since then just to keep talking about the issue. And unfortunately, while there are improvements in some areas, many areas are still lacking. So this is concerning. And yeah, once I start the presentation, then I think we can touch on what doesn't seem to have changed. So I'll go ahead and share the screen, and I will start the presentation so we can talk about racial and ethnic health disparities. So my contact information is on here if anyone needs to reach me. I recently started, I'm working on a group practice, and it's called Africulture Counseling Center. So I am looking for an intern if anyone knows someone, but that's a different conversation. All right, so let me stay focused here. I know it's 6 o'clock and the brain's all over the place, so I will do my best to stay focused. So what are we trying to accomplish today? So some of the objectives I hope we cover is to discuss how provider perceptions, education, training, and knowledge of health disparities influence how they practice, to also explain changes in racial and ethnic health disparities in the last 30 years, to discuss association among current events and racial and ethnic health disparities, and then also to recommend ways providers can identify, racial and ethnic disparities impacting their clients. Okay, so who am I? So as I've said, I am an adjunct professor at 2 universities, and I also am in private practice, so I do see clients as well. So most of my time is balanced between teaching and seeing clients. The study I conducted for my PhD was on MFTs, perception and knowledge of racial and ethnic health disparities. And so interestingly, when we do self-assessments and, we start to try to figure out who we are and how we're drawn to certain things in life, my birth, I think, was probably the beginning of where my interest in health disparities came from. So I'm the 4th child of 5 that my mom had. Back when we were living in Zambia, which is where I was born, it turns out that the doctor or, the gynecologist who was treating my mom had this idea that, Black women shouldn't have too many children. And so, she was trying to find ways to reduce the number of children born to Black women. So when my mom was pregnant with me, she was given Pitocin, which is a medication that can help to induce labor, but it can also have severe consequences on the fetus. And so pretty much I ended up being born premature. I almost didn't make it. And my mom actually named me after the nurse who helped to deliver me. So this is how I was named Dorcas. But the story is interesting to me because, interesting that the white doctor in an African country was trying to reduce the population of Black children. And so the goal was to get rid of me, so to speak. So, I am proud, obviously, that didn't work. And so I think I was put onto this world to sort of, continue this conversation about health disparities and what happens to people of color. All right, so here is a quick poll. And since it is a small group, I think, you can put your answers in the chat. So, and I can see what your answers are. If you want to shout them out, you can do that as well. But this is just so I kind of get an idea of where you are when it comes to racial and ethnic health disparities. So for the first question, of all of the following are resources for information on racial and ethnic health disparities, except you can shout out your answers or put them in the chat.
I must confess, I don't know enough about any of those organizations to know the answer.
Yeah.
And I think Caitlin has the same opinion. How about you, Jennifer? Do you?
Honestly, I don't. I would probably go with that, except National Institute of Health, because it seems like the biggest one, and if it doesn't have information, then that's why it's so bad.
Okay. All right, well, this is great. I mean, I think it confirms the reason for having this presentation, right? So we will discover the answer down the road towards the end of the presentation. What would your responses be to the second question? Comfort discussing health disparities with your clients.
Jennifer, Caitlin, thoughts?
I'm comfortable, but yes, like Caitlin says, I don't think I'm be very helpful. I'm not familiar with.
Okay, so I would say, I guess, Jennifer, your answer would be somewhat then?
Somewhat, yeah.
Somewhat. Okay. Dr.
See,
Spooky, what
I'm
would you-
cheating because I've talked with Dorcas about this topic before. So absolutely, yes, I'd be happy to be talking about this.
Okay.
Absolutely. Though I must say, it would be way easier for me to talk about health disparity as
Yeah.
opposed to mental health disparity. So being
Okay.
having to look at my own profession
Yeah.
as not doing a good job of this would be a little tougher for me than health disparity. I'm happy to talk about their challenges in, getting doctors and dentists and all of that sort of thing. Yeah, that would not be a difficult conversation to have. And the same with my theoretical approach. I don't see any of my theoretical or at least the way I look at my approaches from a very postmodern perspective as getting in the way of
Okay.
my ability to be curious.
Mm.
Jennifer, Jennifer's a student, so you're pretty easy early in the game. What do you think?
I think I would be curious. I definitely think I'm curious.
Yeah.
I
Okay.
just don't have the knowledge.
Yeah. Understand. All right. Caitlin, do you want to put a response in the chat to question 3?
Agree with Schooley. I don't see my theoretical approach would interfere with curiosity.
Okay,
Yeah.
fantastic. All right. Okay, let us move on. So in 2020, Black Lives Matter was huge. And protests, I mean, were beyond the US, to other countries. So why, I would like to hear from you all, why do you think people were protesting?
I think they were fed up with the lack of, well, the inconsistency with help across the board from any federal agency, really. I mean, I'm sorry, I mean, like the police, health, everything. Sorry, I can't get my words out.
Okay, yeah. So numerous factors. Yeah, okay. Anyone want to add something to that?
Kate, I think I should should have studied up before we came to this. That's okay. It's all right. The showing our ignorance is useful for recognizing this is the MFTs. We have a not so much maybe a blind spot, but just kind of a lack of knowledge altogether.
Yeah.
I appreciate this question, and I think that after watching numerous listening to podcasts and interviews and things like a conversation with a Black man and things like that, I think what it is the overwhelming lack of awareness of white privilege and how that gets in the way of absolutely everything. There isn't one aspect of life that doesn't get touched by this issue of white privilege. And our current, in the US current political situation where they've done away with affirmative action in college admissions. And then he's, at least here in Florida, as it is July of 2023 at the time of this taping, that 20 states are banning the use of affirmative treatments for transgender people. It's just this belief, this patriarchal belief that daddy knows best, and doesn't realize that he has privilege, and it's
Yeah.
been 400 years of
Yeah.
daddy thinking he knows best.
Yeah. Yeah. Well, I'm glad to hear you mention white privilege, because yes, for sure, it dictates how things work, not just in the US, but in many countries. And obviously for people of color, when you hear, all lives matter, blue lives matter, nobody is disputing that all lives matter, right? But then when we think about how disenfranchised Black people are, or BIPOCs, American Indians, I mean, the list is endless. And so the protests were a boiling over of all the suffering for generations that people have experienced and endured and continue to experience. And this was just a way of trying to let the world know we've had enough, we can't take this anymore. So unfortunately, George Floyd's life had to be sacrificed on national TV for some people to realize that, this is what's happening to Black men and other people of color. So I'm hoping that with the presentation and everything that I do discuss, you will end up getting a clearer idea of what the lives of BIPOCs are like, on a daily basis. That is, from the time we wake up until we go to bed, we are aware of our color. We're treated based on our color. And so there are many factors that go into how we present in the world, and why, yes, we are angry, and why we were protesting, and why, unfortunately, very little has changed. All right, so just to be clear, so when I did the study, I was focusing on racial and ethnic health disparities. So in the US, ethnicity is determined by Hispanic or non-Hispanic, right? And so the reference population is always the population. So when studies are done, they're looking at, Blacks, American Indian, Alaska Natives, American, Asians. And so the emphasis of my study was to look at the racial and ethnic health disparity. And so that does not exclude other vulnerable populations. So what I'm saying is, I do not want to minimize the experiences of other vulnerable populations. And those include women, children, older adults, people with special needs, people, sexual minority populations. And so those are also included in the definition of vulnerable populations. But once I start talking about my study, the emphasis is on race and ethnicity. All right, so why racial and ethnic health disparities? So the first report on minority health was done in the early 1980s, I believe. At the time, the Department of Health Secretary was Margaret Heckler, if I remember her name correctly. So she was in charge of the task force, and they compiled a report to identify what are the factors contributing to the major disparities, especially for minority populations. So this was data from 1979 to 1981. And the task force identified that the 6 major causes of death accounted for more than 80% of mortality among Blacks and other minority groups. And so these areas were cancer, heart disease, substance misuse issues, diabetes, homicide accidents, and infant mortality. All right, so keep this in mind as we go on, because then we will take a look and see how much of this has changed or improved. Okay, so the leading causes of death in 2017. So most of the data that I am citing here is from the Department of Health and Human Services. They have an agency called the Agency for Healthcare Research and Quality. And so they compile reports every year to demonstrate improvements in the quality of health for the US population. So this is a report from 2017, and I just showed you data from 1979 to 1981. So we can see heart disease still at the top of the list, cancer still at the top of the list, unintentional injuries still at the top of the list, chronic lower respiratory diseases included, strokes, which was also included with heart disease at the top of the list, Alzheimer's, diabetes is still there, pneumonia, flu, suicide, kidney disease. Okay, so most of those 6 are still listed on here. This is as of 2017. Okay, so all right, so what are the factors that contribute to racial and ethnic health disparities? Access is a huge one. And so social determinants of health, which I will also talk about later, is another factor. And so what are social determinants of health? So this is basically conditions in which people are born, where they grow, where they live, where they work. And so this is how, again, for us as mental health providers, it's necessary for us to understand all of these aspects of clients coming to see us. So, as a supervisor and a professor, something I see often is, students in training or trainees, they have a client who shows up and their symptoms are depression. There's the tendency then, all right, let's focus on the depression and figure out how we can lower your symptoms, right? So reduce frequency and intensity of symptoms. But have we asked questions about where do you live? Where do you work? What is the transportation you take to get here? What is your home environment like? Do you live in an area where there's sidewalks where you can actually go outside for a walk? Or do you live in a neighborhood where there's a lot of violence and it's not safe for you to go outdoors? All of these factors can contribute to someone experiencing depression. So if we do not assess for these, we are missing the mark in our treatment. Okay. So going down the list of factors, healthcare coverage, thanks to President Obama, when he was in power, he approved the Affordable Care Act, which was also referred to as Obamacare, which gave access to health care coverage for a lot of people in the US, a lot of families as well. All right, so there is the cost of healthcare as well. Not everyone can afford it. And so this is something that you see people making tough decisions about. Do I pay for health insurance or do I pay rent or, bills in the home? There is also a critical shortage of healthcare providers, and not just healthcare providers in general, especially in rural communities, but also providers of color. And so we know in the mental health field, over 80% of the providers are white. So someone like myself seeking mental health services, I am going to likely run into a provider who's white, who may not be familiar with my cultural background or experience, right? So that is something that makes me question, do I want to go for therapy, or am I better off trying to figure this out on my own, self-medicating, right? So culturally and linguistically competent healthcare, again, what do our providers understand about culture? And are we using assessments, documents, services that are linguistically appropriate for the clients that we're serving? So this is one of the challenges as well, where a lot of the material in healthcare is at a high school level, where some clients aren't high school graduates, so they don't understand what they're reading, but they're also afraid to say so as well, right? So I've already, talked about the non-diverse healthcare workforce, which is an issue, mistrust of healthcare systems providers. Now, the mistrust, especially for people of color, this goes very deep. If we think about things like the Tuskegee experiment, where Black men were, injected with syphilis, supposedly under the guise of research studies. These historical events created a lot of mistrust for people. And so, minorities will always be questioning, if a provider who is not of my race, are they looking out for my best interest? Can I trust them to take care of what is best for me? So this is a really, really deep and concerning issue, because it also does not seem to be changing much. Then, of course, we have to think about the impact of racism, discrimination, and bias as well, and how that shows up in mental health for our clients.
Dorcas, can I
Okay,
ask a
so,
question in here?
oh, of course, yes.
So, I know this is outside of your research, but I don't know what the vaccination rates are by racial ethnic groups, and I was wondering if there was a less adherence to vaccinations for COVID because of this mistrust, or because it was white practitioners that were administering the vaccines or talking about the vaccines. Do you have any knowledge of that?
Well, I mean, that's a fantastic question, and I will just share based on my experience. I haven't honestly looked at the vaccine rates recently. During the pandemic I had, and I will tell you, I received so many emails from different organizations that serve people of color, encouraging us to go and get the vaccine. So they're NAACP. I mean, so many of them were really trying to reach out and promote, getting the vaccine, why it's important, why it is necessary. And something I will share as well, I'm originally from Zimbabwe. Dr. Schooley knows that, because we've worked together before. But I was born in Zambia, like I said. My parents are Zimbabwean, and there were stories coming out from some African countries where they were getting vaccines coming from China, that people, it clearly said on the label, not meant for use in the US or, other countries. So obviously, when I share a story like my birth story, you will always question the intentions of the people bringing these vaccines specifically to these areas. And so a lot of Africans, and at least in Zimbabwe, did not get vaccinated. The president of Zambia was also refusing to allow these vaccines into his country for the same mistrust issues. So this is ongoing, right? This is an ongoing problem. And unfortunately, I think it's going to be a difficult one to resolve, because we continue to see and hear stories where, some, person, usually white, is trying to do something to destroy the minority population. So I don't think this is going to change anytime soon as well. So talking about social determinants of health, now it's impossible to talk about racial and ethnic health disparities without discussing social determinants of health. So what are they? So these are that were identified by the World Health Organization to help understand what factors contribute to poor health for populations. And so, access, like I mentioned before, healthcare quality, social, person lives, where they work, income, and so all of these are just examples of what social determinants of health are. So I'll show part of a video. We don't have to watch the whole thing, but I think this video, which comes from Colorado, does a good job of explaining what social determinants of health are. So I'll only play part of it, but you can watch the rest of it in your own time.
Health starts long before illness in our families, homes, schools, and jobs. Many Coloradans experience barriers to good health due to interfering factors in their lives. These factors are social determinants of health and can make healthcare more challenging for healthcare providers and patients. Some examples of these include income, education, race, and ethnicity, but there are many more. In a typical healthcare appointment, there may be signs that a patient is struggling with challenging life circumstances, which may inhibit successful treatment. However, there are also many ways healthcare providers can help patients get the care they need. This is an opportunity to identify the social determinants affecting a patient's health and utilize creative solutions to help overcome those barriers.
Good morning. Hi, I'm here for an appointment at 9 with Dr. Wilson. All right, let me see what I can do.
Transportation affects the health care of many Coloradans.
Looks like I can still get you in today. Next time, if you're more than 15 minutes late, we're going to have to reschedule. Sorry about that.
22 out of 29 Colorado communities surveyed about their healthcare needs identified this as a major issue, causing late arrivals, missed appointments, and hesitancy to make follow-up appointments.
Transportation affects people's ability to get to their doctor's offices on time and also to be able to stay for that appointment. So if you have to use the bus, you have to get a ride with a friend, it can really impact anybody's ability to actually get there. It's not only important for the well visits and the kids to get their shots, but the sick ones have to come back to be seen again. Otherwise, it's incomplete care.
Lack of transportation is also one of the main reported reasons low-income patients may be forced to rely on more expensive care in the emergency room over managing their healthcare needs with a primary care provider.
Great. Go ahead and fill this out. Okay, thanks.
Literacy and health literacy are also important social determinants of health. 10% of Colorado adults lack basic literacy skills, meaning they are unable to read and comprehend a simple block of text. This makes completing tasks like filling out forms, following written instructions, or locating an expiration date on prescriptions difficult.
Okay, ma'am. We can take you back now.
Additionally, studies suggest patient comprehension may be compromised if content exceeds a middle school reading level. Most medical information was found to be written between a high school and college graduate level.
I think the handout is a good thing, but it can also, we feel like we're covered as a provider by just being able to give this patient a handout. So actually talking to the patient about, so what do you want out of this appointment? What can we do for you? and then saying, here's this handout, and then going over it with them to be like, this is more for you at home, but right now you're here, I'm here. What do you need to know? What can we do to improve your health outcomes?
Looking at your medical record, I really think it's important that we get your blood pressure under control, as well as your hyperlipidemia. The reason I mention that with an elevated blood pressure,
I really enjoy nursing and the role of nurses as being the bridge for the patient, because sometimes they'll have a very long, what I think is a wonderful encounter with their provider, but when it's finished, they have no idea what just happened. And they obviously they do, but they didn't get out of it what they needed. I had a patient today, and the medical student was saying, have you ever had an MI? Answer is yes, but the patient was like, no. Anybody in your family? No, even though he was in for a follow-up for an MI, which is a heart attack, a myocardial infarction, but they didn't ever say, do you have any problems with your heart? And so it's always nice to kind of step back and say, so what questions did you have for your provider? Where can we fill in those blanks?
All right, so I'll stop it there. And yes, I think it's a great video that really helps to explain what social determinants of health are. So, I'm happy to, share the link. You can keep watching it in your own time. So let us continue here. So just a breakdown. Can you see how did it switch for you? Okay. All right. So when we talk about economic stability, right, we're thinking about employment, income, expenses, bills, support, neighborhoods, housing, transportation, safety, playgrounds, walkability score. This is something you see often in many neighborhoods. When we talk about education, again, the literacy, language, access, higher education, so the options, community, what does the social support system look like, discrimination, stress, and then the healthcare system, healthcare coverage, provider availability, provider linguistic and cultural competency, and of course, quality of care. And so all of these factors determine health outcomes, right? So they determine how long a person will live, what expectancy will look like, what their health care costs will be, health status, functional limitations as well. Okay, so why are social determinants of health important? Because they help us to understand the relationship between how population groups experience the place and the impact of place on health. Okay, and this is fundamental to social determinants of health. So we must understand not just the place, but also the impact of the place, right? And so they help us to identify resources that could enhance the quality of life, such as safe and affordable housing, access, public safety, availability of healthy foods, and so on. And then I've already talked about examples of social determinants of health. All right, so now we're going to touch on one of the factors that contributes to racial and ethnic health disparities, which is quality of care. So in 2016 to 2017, Blacks, American Indians, Alaska Natives, Native Hawaiians, Pacific Islanders received worse care than whites for about 40% of the quality measures that are used, right? Disparities were improving for only about 4 measures for Blacks, 2 measures for American Indian, Alaska Natives, and 1 measure for Native Hawaiians, Pacific Islanders. Hispanics received worse care than whites for about 35% of the measures. From 2000 to 2017, disparities were improving for 5 measures for Hispanics. Asians received worse care than whites for 27% of the quality measures, better care than whites for 28% of the quality measures, and disparities were improving for only about 2% of the measures for Asians. So the report I mentioned, which is produced by the Agency for Healthcare Research and Quality, they use over 100 quality measures. And this is what they use to determine what's improving and what's not in terms of quality of care. So this was quality of care by state. This was from 2015 to 2017. And so we can see that all the states that are in gray had the worst quality of care for Blacks, Hispanics, and Asians compared to whites. California, Texas, Minnesota, Wisconsin, Illinois, Ohio, New York, Pennsylvania, South Carolina, Connecticut, and New Jersey. So this was data from 2015 to 2017. If we look at the most recent data from 2016 to 2021, we actually see that more states have been added to the list of worst quality of care. So California and Texas are still there. Montana, Wyoming, Nevada, Arizona, New Mexico, Oklahoma, Mississippi, Georgia, DC, these are all new states that have now been added to the list. Okay, and so again, this is something we are wanting to recognize and understand what it really means, you know. So as a person of color, when you see non-people of color, you know, get upset and talk about, well, we've made so much progress and we've made so many strides, and why are you protesting? And, you know, you couldn't vote in the 1960s and now you can. Well, I mean, why is it that some states are still not to give us the same quality of care, right? And without health, I mean, nothing else matters, right? And so these are some of the things that are concerning and discouraging. But of course, we do want to recognize the states that are doing well. I think those that have consistently provided the best quality of care, Utah, North Dakota, I believe, Maine, I think is one of them. Pennsylvania was on the worst on the previous slide, and now it's one of the best. So, you know, it would be interesting to find out what Pennsylvania has done to make those changes, right? All right, so access to care. So this is from the 2016 to 2017 report. So if we look at the poor versus high income, everything rated in red means out of 20, right, 19 as far as access measures were worse for poor income versus high income. So only one of these access measures was actually the same, and the rest were worse, okay? If we jump to Blacks versus whites, 9 out of 21 got worse in 2016 and 2017. If we jump to Asians versus whites, 7 out of 19 got worse for Asians. If we jump to American Indians and Alaska Natives, 5 out of 11, so pretty much half of the access measures got worse. And then if we look at whites versus non-Hispanic whites versus whites, so this pretty much stayed the same, right? So there were no changes there. And then finally, if we look at Hispanics versus whites, 15 out of the 20 access measures got worse. And this is 2016, 2020. Okay. All right, so the concerning racial and ethnic health disparities. So when it comes to cancer, African Americans have higher death rates than all other groups, many, but not all cancer types. African American women are much more likely than white women to die of breast cancer. African Americans are more than twice as likely as whites to die of prostate cancer, and nearly twice as likely to die of stomach cancer. If we look at colorectal cancer incidence, it's higher in African Americans than in whites. So incidence in all groups is declining, but the difference between the groups is still prevalent. Hispanic and American Indian Alaska Native women have higher rates of cervical cancer than women of other racial ethnic groups. And African American women have the highest rates of death from cervical cancer. American Indian Alaska Natives have the highest rate of liver and intrahepatic bile duct cancer, followed by Asian, Pacific Islanders, and Hispanics. American Indian Alaska Natives have higher death rates from kidney cancer, and the incidence of lung cancer and death rates are also higher in African American men than in other racial groups. So are we surprised that cancer was at the top of the report in 1980s and it's still at the top of the report in 2020? Okay. So in 2016, HIV/AIDS, the measures with the largest disparity for Blacks included new HIV cases per 100,000 population age 13 and over, and the HIV infection death rate per 100,000. So this was in 2016. HIV has been around for decades, and it's disheartening to believe that it still disproportionately impacts people of color, right? The rate of HIV infection for Black American females was 15.1 times the rate for white females. Blacks were more than 7 times as likely as white to die from an HIV infection. According to the CDC research in 2017, Blacks accounted for 13% of the population, but 43% of new HIV cases. Dr. Schooley, I know you know this because you teach HIV. So this stat has not changed from when you started teaching, right?
It's remained disgustingly consistent for decades.
Yes, yes. And so, you know, I mean, you know, one of my goals of discussing racial and ethnic disparities is I'm always hopeful that any provider who's listening to this at least can take away, what can I do? What is my role in all of this? Because I do see clients of different races and ethnicities, and when they're presenting to, you know, therapy, do I know all of these other factors that could be contributing to their mental illness? You know, some are still too embarrassed to say they have HIV/AIDS because of the stigma associated with the disease. You know, I know individuals in Zimbabwe and other African countries who are ashamed to go and get treatment because of the stigma. So they are dying for that same reason, because of, you know, how they might be treated by healthcare providers. So, you know, it's just alarming when it comes to HIV/AIDS as well. And so we can see the rate is also higher for Hispanics, 22.5%, compared to non-Hispanic whites, 6.1%. All right, so when it comes to children, you know, children are not exempt from health disparities. African-American children are twice as likely to be hospitalized and 4 times as likely to die from asthma as non-Hispanic white children. In 2016, non-Hispanic Blacks reported 220.8 children per 100,000 were admitted to the hospital for asthma, compared to 45.9 per 100,000 cases for whites. So, you know, the numbers are also startling when it comes to asthma and how it's impacting our children. And so this it's not only a health issue, but then we also have to think, how is it showing up in their education and their school and how they engage, if, you know, these are some of the issues that they have. And there is a study, I think I had included it in my dissertation, which showed that most of the minority children develop asthma based on the home environments that they live in, the lead, you know, and so that is something to be attentive to. Housing, you know, where people live, where they're coming from. And, you know, we don't even have time to talk about Flint, Michigan and the water crisis, right? That's another story altogether. But children, unfortunately, bear a lot of the burden of disparities. So childhood obesity affects racial and ethnic minority children at much higher rates, driving up the rates of associated diabetes, right? In 2013 to 2016, 25% of Hispanics and Black and non-Hispanic Blacks, 23%. So these are children ages 6 to 17 were more likely to have obesity issues than white non-Hispanics. The rate for them is 16%, Asian, non-Hispanic as well, 11%. So we can see much higher for Hispanics and Blacks. Okay, jumping ahead, sorry. In 2002, 27.6% of children in low-income households had preventative dental appointments, and the percentage increased to 40.9 in 2016. So basically what this is saying is the number increased in terms of they're not getting regular dental care, you know, and so jumping from 2002 to 2016, it's almost the numbers have doubled. And we will see that when it comes to health insurance coverage as well. And so we can see from 2000 to 2016, children who had a doctor's visit or clinic visit in the last 12 months, that treatment worsened for them. So it's not getting any better for children as well. So COVID, this was a report that was done during the pandemic. The numbers might be different at this point, but during the pandemic, it was known that the virus was killing more Hispanic and Black children as well than white youth students. And I think we also know some of the factors contributing to this. Do you all remember what else was going on during the pandemic that was impacting minority households more than non-minority households?
Loss of jobs.
Loss of jobs, exactly. And what else? Access to education, right? So
Oh, right. They don't have the internet. They don't have the laptops to be able to do distance. Yes,
right.
yes.
And you know, some minority families live in multi-generational homes. So there are numerous family members living in one home. And so there's no privacy, there's no, you know, if children have to share a computer, that became an issue as well. So these were some of the concerns that came up during the pandemic as well. All right, so this is a research report. So I showed you the number of children who had appointments for routine care. And so this is from 2019. This shows children who had any appointments for routine health care in the last 12 months who sometimes or never got an appointment for routine health care as needed. So as of 2019, it got worse for Asians, it stayed the same for Blacks. Multi-race, it stayed the same. For Hispanics, it got worse. Asians, Blacks, again, this is based on ethnicity, it got worse. And then based on income, again, it also got worse for those, you know, below the poverty line. And so this is 2019. So some of this is not improving at all. So what have been some of the improvements in racial and ethnic health disparities? So person-centered care. So almost 70% of person-centered care measures were improving overall. Patient safety. So more than 60% of patient safety measures were improving overall. Healthy living, almost 60% of healthy living measures were improving. Effective treatment, almost half of effective treatment measures were improving overall. So from 2002 to 2015, disparities between American Indian, Alaska Natives, and white decreased for the percentage of people with a usual source of care. So this basically means that American Indians and Alaska Natives were able to get a usual sort of care more so than they had previously. Right. Care coordination, 1/3 of care coordination measures were improving, and there were significant decreases in the percentage of uninsured adults that were observed from 2013 through 2017. And this was most likely attributed to the Affordable Care Act. Now, there is a report that I will show. Let me just keep track of the time here. Are there any questions? I feel like I'm rambling a lot and I'm throwing out a lot of information. Does anyone have any questions?
Well, I just want to highlight that that these health measures, it sounds like there were several categories, and that in some categories there was improvement, but in other categories it either stayed the same or got worse.
Yes.
But those actually all varied depending on ethnic group. So while overall things got better or got worse, within group, you had a lot of variability. Do you the categories of these measures? Do you have a slide that shows those categories, or could you name some of the
So
categories?
if you go to the Agency for Healthcare Research and Quality, there they give you all the reports that you want to see, and they will give you a breakdown of the quality measures as well. So I do know they use over 100 different measures to rate. And so, yeah, I mean, it's everything from hospitalizations to, in-home care. There's such a variety of areas that they use to measure quality of care. But if you go to their website, and in my references, there's information on how you can access this as well.
Great.
But yeah, they have over 100 different measures that they use to assess improvements and what's working and what's staying the same. Okay, so I'll quickly zoom through the other slides so you're not here all night. But I will say some of the challenges of eliminating racial and ethnic health disparities are, one, measuring. This is a challenge, right? Measuring health disparities, there's inadequate data on race, ethnicity, and language. And so this lowers the likelihood of effective actions to address health disparities. Also, definition of race and ethnicity. This is something that is not agreed upon, so in some studies, they may just talk about Black versus white. In other studies, they'll give a breakdown of what includes Black. In many studies, Hispanics are grouped together when we know that is not the case. And so we cannot treat Hispanics as a group. If they're Cubans and they're Mexicans and they're, Peruvians, then if they're all coming with different challenges, then we want to be able to address them based on their, country of origin. And so these are some of the challenges that are encountered when trying to address racial and ethnic health disparities. Jumping ahead. And then the behavior change model. So the behavior change model basically says, researchers who use the behavior change model blame individual behavior for why disparities don't improve. So it's basically like saying, start eating healthy foods so you can lose weight, so you're not obese, so you're not encountering, challenges with diabetes. And so, obviously it's problematic because we've already talked about the social determinants of health. So if someone does not have a choice but to live in a neighborhood where they don't have access to healthy food, we can't expect them to make behavior changes, right? So I think that is one of the challenges with the behavior change model. Okay, and so I'm just gonna skip through this one. And so here's a more recent, this is more recent data on the number of people under age 65 with health insurance. This is in 2020. And we can see all the orange, right? So in 2020, healthcare coverage has worsened for many populations, right? And again, we can talk about politics and how that played a part in all of this. But if people don't have access to health insurance, how can they afford to schedule doctor's appointments and get treatment for cancer if they can't afford it? So as you can see, I think there's so many areas here that are worse than only one state actually got better, which was for Asians. A few stayed the same, but all the others got worse. Okay. All right, so here's a quote that I like. And Matthews, I have listed her book in the reference section, which I think speaks volumes. So you can read this, and if you have any comments, I'd like to hear. Okay, and so when we talk about mental illness, we are talking about all of this, right? Someone is not just coming in with a diagnosis of bipolar or whatever it may be. Is where do they live? Are they facing eviction? Are they victims of predatory lending schemes and payday loans, right? Where they pay such a high interest that they'll never be able to catch up and pay, right? So this is what Matthews is referring to, is we can't just look at discrimination on the surface, but we want to understand how it has infiltrated every area of life for a lot of minority populations. Okay, so yeah, this slide should have come, I think, when I was talking about COVID. I'm not sure why it's here, but this gives you some data on COVID deaths and we can see again how Blacks, Hispanics were significantly dying of COVID compared to whites. And it's not because they didn't take care of themselves, but when we think of all the layers contributing to their poor health, it makes a lot of sense why this is the case. All right. And so, yeah, we talked about, why the rates were higher for minority populations in terms of COVID. Most of them could not work from home. They had to keep going to their jobs. Some of them worked in factories and were still exposed to each other in open environments. Comorbid issues, using public transportation to get to work, not insured access, poor quality of care, and then, victims of factory farming, brutality, and other substandard working conditions. All right, so this is pretty much what we've been talking about. Who is protesting and why? So now we are hopefully getting a better idea of why people were so passionate about Black Lives Matter and everything that goes on in the homes, in their communities, in their environments, in their workplaces, you know, and how it shows up as police brutality, which I will touch on again here. All right, so where you live, social determinants of health makes a big difference, right? So Blacks are 3 times more likely to be killed by police than white people. If you live in Oklahoma, you're 6 times more likely to be killed by police than in Georgia. So where you live matters. It makes a difference, right? And so this is a recent report from Police Mapping website, which has been tracking the number of police murders. Right, so 2020 is when George Floyd was murdered, and there were protests, you know, police reforms. What has changed?
Got worse.
Got worse, right? We can see that in 2022, more people have been killed by police than any other year in the past decade. So something is not working, right? Between the leaders at the top, us as providers, and the people who come to see us, there is a major disconnect there. And so most unarmed people killed by police were people of color, 32% Black, 19% Hispanic, 3% Asian, Pacific Islander. And so, yeah, most of them unarmed, and they were people of color. So, you know, and down here, I also just added the statement, 111 people were killed. This was in 2022, after police responded to reports of someone behaving erratically or having a mental health crisis. So again, I think on the work we do, how we're doing it, and what we know about our clients and where they live, right? And so if you work with clients of color and you tell them, you know, in an emergency, call 911, most of them will tell you, I am not going to do that because I am more likely to get killed by the police who's coming to my home because I'm a person of color. So these are things that we also want to understand. All right, so other examples of social determinants of health. So where you live makes a big difference. This is an old report that I had found while I was in Chicago in 2019. And so these are differences in neighborhoods in Chicago. So Streeterville is upper white class, great neighborhood in Chicago. Englewood is on the south side of Chicago, you know, and so if you live in Streeterville, which is up here in this fancy neighborhood with all the museums and river walks and everything beautiful and pretty, you can live up to age 90. If you live in Englewood, you are likely to die by age 60. These two neighborhoods are less than 10 miles apart from each other, right? And this is all in the same neighborhood in the same city in Chicago, right? So, you know, what does a resident in Englewood have to look forward to if they're unemployed, underemployed, if they are receiving worse access and quality of care, if they encounter racism and discrimination on a regular basis, you know, they have mental and physical illnesses, you know, and they recognize that the American system views them as a threat or a lower class citizen, then what do they have to fear except face the violence that's in their neighborhoods? So what if I go out and get killed? It's either me getting killed or somebody else who will, you know, I will have to kill to survive. So I think something to touch on that I may not get a chance to touch on is we also want to think about how we diagnose our clients. Oppositional defiance disorder, if we are giving this diagnosis of conduct disorder to young Black men, this follows them throughout their lives. They are treated like a threat by police because you are said to be oppositionally defiant or you have conduct disorder. So these are things that we want to pay attention to as well. Okay, so I'm going to start jumping through quickly so I can talk a little bit about the study that I did. So the study I did was a survey that I sent out to MFTs all over the US. And I asked a number of questions about racial and ethnic health disparities. And so, we can see, these are just some of the results of the studies. So the statement was MFTs who are knowledgeable about racial and ethnic health disparities can provide more competent service. And most agreed, right? And then my supervisor discusses racial and ethnic health disparities in training. So I think we can see very frequently was the highest here. Not always, but pretty frequently, occasionally frequently. So these were good numbers to see. And so here's the question that I asked you all at the beginning in the poll, right? All of the following are resources for information on racial and ethnic health disparities, except. And so we can see almost 50% were not sure about the resources, right? So National Institute of Health is, and they do provide information. Kaiser provides a lot of information. The CDC provides a lot of information. Veritas Health is not. So this is the one that has nothing to do with racial and ethnic health disparities. And so there also was a question here. I know where to find information on racial and ethnic health disparities. 76% indicated yes. But however, when we look at this answer to question 39, people actually didn't know where to find the information. Okay. So a framework to eliminate health disparities. So this is, taking into account the healthcare system factors. So the organizations, the culture of the organization. We also want to consider patient factors. So what are the patient's, clients' beliefs, preferences, race, ethnicity, education? Education was mentioned in the social determinants of health video, and the clinical encounter. So what is that encounter like for clients coming to seek therapy? And then providers ourselves, what do we know? What are our attitudes? And how competent are we? How biased are we as well? Okay, and so this was a comment that was given in the survey that I did for my dissertation. So I want you to read it and let's talk about it quickly.
Shall I read it out loud?
If you wish.
While it is obviously very important for us as providers to be sensitive to the issues that this survey is targeting, it is also important for the communities that we serve to be careful about personal choices that they make that can hurt them. For example, having more or even worse, many children when you already live in poverty is simply not a wise life decision. No amount of provider sensitivity to cultural preferences for large families is going to help patients who live in poverty pay their bills, cover adequate housing, buy school supplies, etc. While some might say that this sounds racist, it breaks my heart to watch this. Women who have babies against medical advice because their husbands won't allow birth control, children's and families' poverty getting worse and worse at 10, 12 or more people reside in a horrible one-bedroom apartment, etc. It is not something that should be excused as cultural and thereby okay. Oh my goodness.
Yes. Where do we begin, right? Where do we begin? Yeah, so, it's, as much as we hope and want to believe that we all get into this profession because we want to do good and we want to make a difference, unfortunately, what we think, what we believe, you know, is going to show up in our work and how we treat people, So I will also say, as a supervisor, I have seen, if you present a case study of, let's say, an American Indian child who is presenting with symptoms of anxiety and, ADHD and so on, a lot of the white trainees are quick to jump to, let's medicate the child. That is usually a solution that I come across. And so before they get to know the background of this child and where they're coming from, what is the home environment like, what is going on in the home that is going to help us understand and maybe better support this child before we jump to medication as an option, So our beliefs and the way we think, and I think this response, this comment in the survey was very telling, because obviously if this provider is working with a mother who has 6 children in the home, is a single mother who's struggling to make ends meet, you're not going to show some empathy if you believe, why are you having all these children? Get your life together and just stop having all these kids, right? There's no understanding of social determinants of health at all in this statement, so we all have to pay attention to how we think and how that shows up in our work with clients, and how we treat and engage with them as well. Okay, so what responsibility do providers have? So understanding how their perception, training, education, and knowledge can influence how they practice. So familiarizing themselves with the socio-ecological model and how each system in the model shapes their perception of the clients, right? So what are the policies, even at the organization where I work, the community that I live in or where my clients are coming from, institutional policies, interpersonal, intrapersonal. So really understanding all of these different layers and how they show up when someone is seeking treatment for mental health, right? So providers can advocate for changes within their educational programs when they recognize the absence of education on racial and ethnic health disparities and social determinants of health, and also with the organizations when they encounter unjust policies and practices. Now, this is something I also experienced in my years of working in predominantly white institutions or organizations. People don't speak up even when they see discrimination happening. Oh, it's not happening to me, so I don't need to say anything. Oh, I need to keep my job, so I'm not going to say anything, right? But so we are perpetuating, oppression, and we are not doing anything as providers to actually advocate for change, which is a concern. So providers should realize that how they communicate with clients affects a client's desire to return for services. They should know where to find resources and information on racial and ethnic health disparities. They should understand the impact of misdiagnosing minority clients, and paying attention to the impact a diagnosis will have. So as a Black woman, one thing I am fully aware of is I will not get the same treatment for breast cancer as a white woman will. So I would have to understand my diagnosis and advocate for myself and speak up for the types of tests that I need to have, because this is proven in research that Black women will not get the same quality of care, access to care for breast cancer or reproductive health as white women will. So these are things to pay attention to as well. You have a client who comes to therapy, they've been diagnosed with breast cancer. What it means for them is significant, because they already feel like, well, this is a death sentence, right? I'm not going to get the same treatment, so what hope do I have? All right, so providers can cultivate growth by looking at what's happening within their organizations, how minorities are treated. Is there a separation among racial ethnic groups? And if so, why? Why is this separation existing? Do minorities feel uncomfortable speaking up? If so, is that something I can point out and address? And Dr. Schooley, you may have experienced this, I'm not sure, but you're very open, so you probably have not. But in some of my teaching experience, I have noticed when there is one minority student in a class, they will not speak, and I remember days when I was one of those minority students, so I would sit quietly in the back, I would not say a thing, but we want to be able to figure out, is there anything more we can do to engage the student? Is there a reason why the student is not feeling comfortable to speak up? And so also paying attention to the organizations we work for and how are they responding to issues that involve race in and outside of the organization, right? So not just putting out a statement when something happens, but do they actually demonstrate that on a regular basis? Okay, and so in closing, how much has changed for racial and ethnic minority populations? Unfortunately, not much. And so as we see, many have experienced worse, and anything in red is worse. So it hasn't changed much from 2013, 2015, 2016, and 2017. Right? So out of 190 of these quality measures, 76% of them for Blacks are worse. 47 out of 172 for Asians are worse. 42 out of 106 for American Indians, Alaska Natives are worse. And 23 out of 57 for Native Hawaiians, Pacific Islanders, and for Hispanics, 58% out of 167 are worse. Okay, so not enough has changed, unfortunately. And so I think we still have a long way to go. And, we can't work in our offices, rooms, and do therapy, and then step out into the world and pretend that this isn't happening around us. All right, so in closing, this is another quote from Matthews that I loved. Dr. Schooley, you are welcome to read it. It's
Okay.
nice.
Some of the changes pertinent to finding a cure for inequity in American healthcare are decidedly negative. Chief among them is the dreadful resurgence of racism, overt and covert, which has made a comeback in America by every conceivable measure: education, employment, income, wealth, poverty, arrest and incarceration, and food security. Inequities that separate those with advantages from the disadvantaged in America are severe and worsening to level not experienced in this country since the Great Depression of the 1930s. Wow. And that was back in 2015.
Yeah, this is when her book was published. Yeah.
Right. And I'm sure,
Oh.
and she was saying this, she was published in 2015. So she was writing this right as the Republicans came back into the presidency. And And I don't know that it's gotten any
Yeah.
better.
No, well,
Yeah.
it hasn't, as we saw with the stats
Yeah,
on health
with those
insurance.
in health, right, right.
Yeah, so
But
it,
education, employment, income, arrest and incarceration,
yeah,
right, all those other measures. Mhm.
absolutely. Police brutality, nothing has changed. All right, so I think this wraps it up. So questions that you can think about, you don't have to answer, but 2 steps that you are willing to take to address this issue and to think about maybe changes that you can make in how you engage with your clients to reduce health disparities. So how will your conversations change moving forward? When you're working with BIPOC clients, have you experienced discrimination? Tell me about that, so I can understand, because that could be what is bringing them to mental health treatment. If we just focus on, oh, you said you have anxiety, let's treat anxiety, we're completely missing the mark here. So yeah, I think the rest is just some resources. They're all listed in my references, but these are the ones I highly recommend and I have used. And here's the National Healthcare Quality and Disparities Report. So there is a 2022 one that you can also take a look at. Some of the information I did pull from there, but all of these, Health United States is an in-depth report on health in the US. And then this is Matthew's book that I was quoting from as well. And I mean, there's so many others, but I just put these up. All right, so I can stop sharing and we can have a conversation. I would love to hear what everyone is thinking, where you are. Did I lose you at some point? Was it too much?
Well, no, well, is it too much? Yes, it is overwhelming. It's just overwhelming. Absolutely. But we have to swim in it a little bit so that we really can appreciate the challenges. But Dorcas, could you tell us a couple of things that, as a result of your research, that you do with your clients or maybe with your supervisees as a result?
So one thing, and this is something I think through teaching that I just realized it's so important and critical to talk about culture. Hence my desire to create Africulture Counseling Center, because I think if we don't understand the client's culture, we're going to miss so much about how to treat them. So I always am having conversations about, and I incorporate a Bowen perspective in my thinking. So I'm always looking at intergenerational factors. It's not just who is the person sitting in front of me, but tell me about your family history, parents, marriages, migration, any issues with immigration, things that are going to help me better understand everything contributing to your mental health. And so these are conversations I have. So if I'm working with a client who's from India and I understand the importance of, family and living in a multi-generational household, then I'm not going to make recommendations such as, become more assertive or, expand your individuality if this is not going to fit with the person's culture. So it's more just how do we engage in a conversation so the person recognizes, okay, now I see how my culture is contributing to why I'm struggling, how the discrimination I'm experiencing at work is contributing. One case example that comes to mind for me is Indian, a client I have from India who's been in the US about 7 years, married to a white woman. And he has been experiencing discrimination at work. at work. Unfortunately, his family is all in India, so he has no support system here. His wife is not supportive because she suffers from her own depression. And so there's no communication, there's no engaging, there's none of that, you know. And when the client first showed up to therapy, it's like, you know, yeah, you know, I'm worried about my mom and my brother in India, and I'm trying to figure out how I can get them here. But then when you look at everything that's happening, it's like, how can you expect to feel okay when you're facing it everywhere you turn, at home, at work, you know, in society, you're discriminated against, you know? So it helps a client to recognize that, okay, I'm not the problem. It's not something wrong with me, but these are all the things that I'm dealing with. And so it makes sense why I could be struggling, right? So culture is just such a critical part of the conversation, you know, so I'm always trying to understand, you know, do you experience discrimination at work? Do you feel included? Do you feel like you have a voice? You know, so tell me about, you know, commuting from home to work and what that's like for you. Are you spending 2 hours catching 2 buses to get to a job, and then by the time you get home, it's 9 o'clock at night, you know? So really using the social determinants of health in the conversation is how I have begun to approach my work with clients. I'm not just looking at, you know, symptoms they report, but I have to understand every aspect of you as an individual, so that I can be more effective in how I work with you.
Mhm. Mhm.
Yeah.
I appreciate that. Yeah, I appreciate as a supervisor, um, I I know that that as of late, I have been asking more about health. When was the last time the client went to the doctor? You know, and those kinds of things, or trying to understand what could be the biomedical aspects of what's the concerns of the client. And of course, that's going to bash right into the disparities and the lack of access for people of color. But also, you know, as a supervisor, remembering to always ask about the culture of the family and how much does the therapist know about it.
Right.
And they may or may not ask about it, and they are more likely to ask about it if they know I'm going to ask them about it.
Yeah.
So that certainly is something that I could do. You know, I mean, I know I do it, but probably not enough, not consistently enough. Yeah, I would like to think that most of our MFT folks know to look for context, to look for understanding, but it's so much. It's you know, having reminders like this can help us. Jennifer, I know you're you know, still are you in internship at this time, Jennifer?
Yes, I'm on my third internship now.
In third, right? So
Number
you're
3.
almost graduated. So what are some things you've taken from this that you'd like to take into your sessions next week?
I've actually been assigned my first African American couple. I've had a lot of Hispanics. I tend to be given the Hispanics because I speak Spanish from Puerto Rico. And so half of my clients are only Spanish speakers. And but what was nice about this new couple, this African American lady, is that she was raised in Jamaica. So she mentioned, you know, island life, culture. And of course, I know what that's like because I lived in Puerto Rico most of my life. So I know, you know, how small the world is when you're living on on a small island and everybody knows everybody. So, you know, I mentioned that to her, and that's like kind of seemed to, you know, please her. She kind of liked that because there was a little bit of a connection there.
Yeah.
And so I really, you know, appreciate it when I can do that for them, because you know, it gives them, I think, less of a distance between us, you know, as therapist and client. You know, we find something in common at least, and it helps with the therapy.
Yeah.
Thanks.
Yeah.
Caitlin, you're up in an area that I don't know, what is the diversity level of where you work up there in Spring Hill?
Oh goodness. I would say not very diverse at all. Primarily, yeah, white culture.
Spring Hill, which state?
Florida,
Oh, Florida. Okay.
north of Tampa is where she is.
Okay.
Yeah.
Okay.
Whereas Jennifer and I are here in South Florida, where, you know, it's there, you really can appreciate a diversity class or diversity issues because you really do see diversity
Yeah.
all over the place. But where Caitlin is, not so much.
Yeah.
Yeah, not so much. And it's a lot harder to teach interns and students who live in a majority white or a vast majority white area. They don't they really don't have the visceral experience of seeing diversity and therefore seeing discrimination and all those kinds of things. So
I do have
and I'm
to.
sure you have that as well, Dorcas, that you have students from all over the country that come with very, very different experiences. And for some people, everything you've just presented to us is either very well understood and yes, we wouldn't be at all surprised. And others are like, I had no idea. So yeah.
Mm, absolutely. Yeah. Well, I mean, who we are, I think, shows up in how we practice. And
How could it not? We know that is true of our clients. Why wouldn't it be true of us?
right. So I think there's a lot of, you know, undoing sometimes that we have to do because we do things unconsciously and we may say things without thinking and recognizing the impact it has on someone else. You know, so there's always thought going into, you know, if I say this, how might this person respond or take it? And it could just be one small thing that makes someone decide, well, I'm not coming back to this therapist.
Or
know?
like in the case of Jennifer, oh, I feel at least a little bit
Right.
understood. Yeah.
Right.
Yeah.
So I put a link in the chat for a book. I helped to do some of the research. This was psychotherapy for Black women. And the research just demonstrates again some of the reasons why Black women may not come to therapy or why they seek therapy. So if anyone's interested in, you know, taking a look at the book, I think it has a lot of valuable information in just understanding the importance again of culture and social determinants of health. We can't ignore that. Yeah.
Yeah. I'm curious, do you recall the participant whose quote that I read that was so disparaging of women who had multiple children? Do you remember where that participant was geographically?
No, I do not. I don't. I mean, I'm sure I can probably go back and maybe see, but because it was anonymous, I'm not sure.
Yeah.
But you know, I mean,
Yeah,
there might be a way.
this is survey.
Yeah.
Survey. Yeah. So that's a lot harder. I would love to have been a fly in the wall if you had done interviews and this person had said that. I would love to have been a fly on the wall to see what you said. Yeah. Wow. Wow. That
Well,
was tough.
I mean, I think it's good to engage in conversation and
Yes.
where I think I see the upside of teaching is
Mm-hmm.
you can have those conversations with students and they may come in thinking one way, but once they are exposed to something, they realize, huh, I never thought about that, you know?
Mm-hmm.
So I love talking about culture because
Sure,
who I
sure.
am and
And that's
I
why I prefer
understand.
the social constructionist based
Yeah,
MFT models, because it requires that we look at multiple contexts
yeah,
and understanding that meanings are created locally and
yeah,
from multiple dominant discourses. So
yeah, yeah,
yeah.
yeah.
Well, Jennifer or Caitlin, do you have any other comments or questions for Dr. Matawi?
No, I just want to say thank you very much for the information. I think it was amazingly interesting, and I'm dying to learn more.
Well, you feel free to reach out to me. I would be happy to share and talk. So however I can be of use, don't hesitate.
Great. All right. Caitlin, any last words?
No, I agree with Jennifer. Thank you so very much for the presentation. It's always good to, be exposed to specific information, especially information that we're just either not exposed to in our own communities or
Yeah.
we don't often think about in the forefront, especially when you're in there with clients. So I appreciate that. Thank you very much.
Oh, no problem. No problem.
Well, so thank you again, Dr. Matawi. And for those who are listening to this on YouTube, I hope you will look forward to additional workshops that we provide and take a look at all the other things that we have listed on our channel. Thank you.